So now we're just going to go over chapter 22, which is communicable diseases. This slide just talks about the immunizations that are required for children from birth to age 6. You have a chart in your book, page 498, but I've also posted a nice chart that I like a little better on Moodle from the CDC. And you don't have to know the specifics of when they're given. I would look at the chart and just kind of have an idea. But most of the time you're going to be referring to a chart anyway to see when the immunizations are actually being given. Just some general considerations that you want to have at immunizations. You want to make sure that you're educating caregivers and patients, depending on the age, on the side effects, including mild fever, soreness, and redness at the injection site are common. Teach calculation of appropriate doses of acetaminophen or ibuprofen for relief based on their weight. And we kind of talked about this earlier in that chapter 21. Provide the vaccine information statement, which we all get, just talking about the side effects to look for, when to seek medical attention, and so forth. Report all adverse effects of immunizations, and then keep appropriate documentation on file. This slide is just going over the immunizations required for children 7 to 18. And you have a good little chart on this on page 501 on your text. And this is just a little refresher for you on the different types of immunity. So active immunity is when a person is exposed to the disease organism and makes his or her own antibodies. And so this is a very permanent or long-lasting immunity. And a natural active immunity is when a person actually has the infection and is then immune to the disease. And vaccine-induced immunity is active immunity to a disease that comes from being immunized with a killed or weakened form of that disease. So active immunity is exposure to the organism, whatever is causing the disease, making your own antibodies. The natural side of this, natural active, is that the person actually has the infection and is then immune. Vaccine is that there's active immunity to a disease that comes from being immunized with the killed or weakened form of that disease. Passive immunity is when a person is given antibodies to a disease. So this immunity is going to be more temporary and lasts only for a few weeks or months. Natural passive immunity is antibodies are passed from mother to fetus by the way of the placenta. Passive immunity is given through immune globulins to provide immediate protection against a disease. All right, so just review that and remember what all that stands for. So different types of vaccines. You have your inactive or killed organism. A good example of this is an inactivated polio virus. So when you have an inactive or killed organism, this is when the virus is disabled. So it's unable to replicate itself, but there's just enough of like its original characteristics that it can stimulate an immune response in the body and give someone that immunity for that vaccine. A live attenuated or weakened virus is good examples of these are MMR and the varicella vaccine. So it can be a live virus, which is going to be like for the flu mist that sprayed up the nose, that's live, or a weakened virus for the IM injection. A cellular vaccine, a good example of this is pertussis or Hib. And this vaccine contains fragments of cells that stimulate an immune response but does not contain the whole cell. All right, so fragments of cells of the virus, not the whole cell. So it stimulates an immune response. Toxoids, good examples of this are tetanus and diphtheria. Toxins produced by the bacteria are inactivated, so they cannot cause harm, but they can still stimulate an immune response. And then a subunit of virus, a good example of this is hepatitis B. And this is when small fragments of the virus's protein are used for vaccination to get that immunity. So just kind of reviewing vaccine routes, intramuscular only, technically the types of vaccines you're going to see that are IM only are going to be your DTaP, your DT, your Tdap, and your TD. Your Hib vaccine, hepatitis A, hepatitis B, HPV, influenza, meningococcal, and pneumococcal are going to be IM. IM or sub-Q, you'll see pneumococcal and polio. Subcutaneous, you'll see MMRs, varicellas, and then meningococcal. And then oral is rotavirus. And the intranasal spray, as we talked about a second ago, is influenza. So those are just kind of good examples of that. So immunizations regarding a correlation to autism, there's actually no evidence that links the preservatives in vaccines to autism. However, there is an advisory committee that has recommended to remove it from all vaccines anyway, just in case, because if there's no reason to have it, then why even put it in there if there's not really a benefit and it could cause more harm than good. And there's also no evidence linking specifically MMR vaccine with autism. So none of the hubbub of what Jenny McCarthy was saying about the autism and vaccine link has been found to be true. So if you have to ever answer that with parents, you can say that there is no evidence that's supporting that, and just kind of stay on top of, if you're going to be in pediatrics specifically, like what CDC and places like that who are actually good sources are telling you about vaccines and what we need to stay up to date on and educate our patients and their parents on. So when you're looking at a patient's history, you want to look at the exposure to the disease. Has a child been around other children who have had this disease? Is the child in close contact with other children at daycares or schools? So what kind of exposure do they have? The incubation period of the disease and the onset of the symptoms. So consider that, what type of disease it is, and the length of time it takes for symptoms to appear from the time that the child was exposed to the disease. Communicable diseases in the past. Have they ever had a communicable disease in the past? Immunization history. What immunizations has the child had? Is he or she up to date on those? Do they need to be caught up on those? And of course, your general physical assessment, including general signs and symptoms that they're exhibiting and those types of things. Just a slide reviewing universal and standard precautions, as we've done a million times before, especially in foundations, what the definition is of universal, standard, and then isolation guidelines, which you are all probably pretty well versed in by now. Situations requiring emergency services. This is based off of communicable disease itself, or maybe a reaction to a vaccine, so difficulty breathing, blue, gray, purple tinge to the lips. You can read through it and see all that would require emergency services. They're pretty self-explanatory. The first viral disease we're going to talk about, erythema infectiosum, which is fifth disease. It's also called slap cheek disease because the children actually exhibit a slap cheek look. It's a rash on their face, as you see in this picture below, and they'll have a little lacy rash on their arms or their legs. The biggest thing is that this is spread via droplet or blood. Incubation period is anywhere from 4 to sometimes up to 21 days before symptoms will appear from exposure. And then they actually won't exhibit any symptoms until you start to get that rash on their face. That's the main symptoms that you'll see. They may have some fever, aches, and headaches, but again, a lot of times this won't even start until you see the rash. So the biggest thing about this is that it is contagious, but a lot of the times you won't know that they even have it until, say, like 2 weeks in. So they've been around all these kids carrying this virus around, and they've been spreading it around to everybody else if they're coughing or sneezing or anything of that nature. So it can be, a lot of times you'll see it kind of run a little rampant in the elementary schools if there is a kid that gets this. But they do have this very prominent rash on their face, fifth disease. So if you ever hear anything about a rash on the face, it looks like a slap cheek, that's going to be your fifth disease. The biggest thing you can do for this is really just kind of let it ride out since it is viral. But parents can give acetaminophen or ibuprofen if they're have discomfort or a fever, and just make sure that they're staying adequately hydrated. The next one is hand, foot, mouth disease, which I'm sure if you have nieces, nephews, children, you've probably run across this quite a few times, and actually adults can get it as well. This is very contagious. It's caused by a enterovirus or Coxsackie virus. It's transmitted by direct contact or respiratory, so if they're coughing, droplets, those types of things, or fecal oral route. Incubation period is anywhere from 3 to 6 days, so you're apt to see more signs sooner than later. Um, Typically, it will show as these small vesicles in the mouth, inside the mouth, on the hands, and on the feet, and around the mouth. It's very, very uncomfortable, especially when it comes to eating or drinking. So you want to make sure that they're able to do so. And that's the biggest part is education, making sure good hand hygiene. And when it comes to eating and drinking, giving bland foods and drinks. That way, like no spice or citrus can, when you have those ulcers and you're really uncomfortable, you don't want any of that. So make sure food and drinks are bland, not too cold, not too hot. And if they don't want to drink a whole lot, they can just do little sips at a time. If they're having lots of pain or even a fever with it, definitely give acetaminophen or ibuprofen. Again, the biggest thing with medications is making sure the parents know how much to give and how to give it. They can also use over-the-counter sprays or special mouthwashes, kind of like that homemade magic mouthwash we talked about in chapter 21. That will provide some local anesthetic to the mouth and throat, and they'll be able to eat and drink a little better. So those are the biggest things with the hand, foot, and mouth. Another viral disease you may see, but not as much, hepatitis A. It's transmitted by contaminated food, fecal oral route. Incubation period is approximately 30 days, and then they are most contagious for 2 weeks before onset of symptoms and for 1 week after onset of jaundice. More than likely, they'll have fever, malaise, poor appetite, feel very nauseous. Jaundice, as I just stated, because it will attack parts of the liver. And so the jaundice will ensue, abdominal pain, and dark urine. And then, interestingly enough, children under 6 won't have any signs and symptoms. So they think that they play a big role in actually transmitting hepatitis A virus. Next, we have hepatitis B. Of course, caused by hepatitis B virus, transmitted by blood or blood products or sexual contact. Incubation period for this is about 90 days. It can be spread as long as the virus is in the blood of an individual, and some people are chronic carriers and carry the disease for life. Signs and symptoms you want to look for along with jaundice, aching, malaise, joint pain, dark urine, loss of appetite, mild right upper quadrant abdominal pain. And remember, when you're assessing for jaundice in darker colored patients with skin tones, look at the sclera of their eyes, because Caucasian lighter skinned patients, you're going to be able to see it in their skin, but darker skin tones, you're going to be able to see it best in the sclera of their eyes. So make sure you're checking that out, okay? Education purposes, you want to teach caregivers not to share any toothbrushes or razors. Lifestyle counseling, if they're risky behaviors, the kids have a risky behavior such as drug use or sexual activity. And then teach importance of treatment and follow-up. Next, we have the flu, influenza. There's different types of agents that cause this. Type A, another type A, or a different type B. Transmitted by contact with contaminated secretions, coughing, and sneezing. Can be spread 1 day before until 7 days after symptoms ensue. So a day before symptoms start and 7 days after symptoms end. You'll see fever, chills, general malaise, conjunctivitis even maybe, and then just full body aches. Of course, they'll do a nasal swab to diagnose this in the hospital or in the primary care setting. The biggest thing about the flu that you want to be mindful of, especially in the hospital, is that in infants it it can actually trigger croup and cause a lot of respiratory issues, so you want to be mindful of that. Caregiver education, you want to make sure that they are encouraging fluids. Lots of parents are going to be concerned about whether or not their child can eat, and they're not eating. Hydration is the most important thing, so make sure you stress that. Just make sure you're encouraging fluids. That's the biggest thing, is if they're not drinking, then that's going to be an issue, and they'll need to come in and get hydrated via IV. Um, Pneumonia is actually a big complication of the flu, and you want to make sure that you educate them to be looking out for signs and symptoms of that. If they're in the hospital, you're definitely going to put them on droplet precautions. Make sure you're aware of what droplet precautions entail. You also want to educate your caregivers not to give aspirin at all, really during any viral illness, but chickenpox and the flu are the big ones. Do not give any aspirin containing products or salicylates. It's like Pepto-Bismol has salicylate in it. Anything of that nature, you do not want to give a salicylate product with aspirin in it, because it can cause Reye syndrome or Ray syndrome, however you want to say it, depending on what you like. But the biggest thing with that is that it's rare, but it's a very serious condition that causes swelling in the liver and the brain. And so typically it's the flu or chickenpox where they're recovering from this and they've received a salicylate product, and it can have some type of complication that leads to swelling in the liver and brain. So signs and symptoms of this would be confusion, seizures, loss of consciousness, and that would all require, of course, emergency treatment. So biggest thing in the flu and chickenpox, do not give aspirin products, Tylenol and ibuprofen only. Next, we have a little mononucleosis. It's caused by the Epstein-Barr virus, transmitted via person-to-person contact or sharing of personal objects, such as cups or toothbrushes, anything with saliva on it. It has a 30 to 50 day incubation period, and this virus may be excreted for months following the infection. And so that's why you'll see children or adolescents who have this, they have to be on bed rest and can't do any sports or activities because they can develop splenomegaly or hepatomegaly, and that spleen could rupture with any type of forceful contact if they fell or they got hit, anything like that. So they have to be very mindful of being on bed rest and not being playing sports for sometimes up to 6 months. It just really depends on how severe it is and how they're reacting to it. So just remember that you definitely want to educate the caregivers on that they can't play any contact sports. Typically it's 6 to 8 weeks, but again, it can go up to 6 months. But if there was a question about it, 6 to 8 weeks would be what would be normal. Definitely lots of rest, lots of quiet, appropriate activities, or they're not being jostled around a lot. If they're having a fever, they can have Tylenol or ibuprofen. Make sure they're well hydrated and they're well getting a lot of good nutrients for their body. And then if they're on too long of a bed rest, like I had a friend in high school that was on bed rest for like 3 months due to mono, you're going to think about the psychosocial piece of that and what can you do to make sure that they're getting the developmental needs that they require. A lot of times too, you may see pharyngitis with mononucleosis. So sometimes they have a hard time differentiating between, hey, is this mono or is it strep? The one thing that will, I guess, come out is if you give an ampicillin or amoxicillin to a patient that has mono and you think that you're treating strep, they're going to have a maculopapular rash on their body. So if you think a patient has strep, they're given ampicillin or amoxicillin and they start developing a rash, more than likely that patient has a mono instead. So they need to be reevaluated and given the right treatment or instructions, because it's viral, so they have to write it out, but definitely want to make sure they're being treated for the correct virus. So mumps or parotitis, you don't see this quite as much, so we have vaccines, but if you do, will start to present itself as painful swollen parotid glands. You also have fever and muscle aches, headache, earache, which will get a lot worse if the child is chewing, and then they'll be real tired and fatigued, and they'll have a loss of appetite. This virus is spread by contact with oral or nasal secretions. 16 to 18 day incubation period can be spread 2 to 3 days before the swelling of the salivary glands occurs, and then up to 5 days after the swelling starts. This is just a visual for you of what mumps looks like. You can see there where the salivary glands have swollen. I mean, that is huge. So that's exactly what mumps looks like right there. Next, we have RSV. It's very common. You will see, especially in the winter months. It is transmitted by contact with saliva and nasal secretions. It can live on surfaces for several hours, and it is readily transmitted by hands. Typically, the incubation period is about 4 to 6 days. Symptoms that you'll typically see in older kids would be a cough, nasal congestion, and fever. And then as the disease progresses, they may have some respiratory issues. However, in infants is really, really important because they may have respiratory distress because they don't have that capacity in their lungs to really handle a respiratory infection or a virus. So you'll see they have with bronchiolitis, they kind of have a seal type cough too. And croup can sound like that as well, but sometimes the RSV and bronchiolitis will have that seal-like cough. So in infants, you really want to be mindful of assessing for tachypnea, wheezing, retractions, anything like that, because they can go downhill so fast. You want to make sure you put these kids on contact isolation, always assessing their respiratory status. Make sure that you're allowing rest time, especially for an infant, because you don't want to overexert them and they start coughing, because once they get in these coughing fits, sometimes they cough for like a full minute and they just can't catch their breath. So obviously that's a bad situation. You also want to make sure they're giving them oxygen if you need it, hydration with IV fluids if they're unable to take anything by mouth. And then they may also require some nebulizer treatments on the side. As far as caregiver education, you want to make sure that they're practicing really good hygiene, disposing of tissues since it can live on surfaces for several hours. A cool mist humidifier can help with easing the secretions in the lungs and kind of making it a little bit more moist. You don't want to give any over-the-counter cold or cough products to kids less than 4 years of age. A lot of times people will try to treat this at home like, oh my gosh, they have a cough, let me give them something. It's bad news. You don't want to give them anything over the counter because some of the ingredients in there aren't good for kids less than 4. Teach them signs and symptoms of respiratory distress and when to seek medical care. And there is an immunization that infants who are at risk get. So if they're born premature, more than likely they're going to receive the Synagis immunization to prevent RSV. So if you see a question about immunizations, RSV, Synagis is what you're looking for. And make sure you educate parents on that to make sure if they have a premature child, they are getting the correct immunization to help with that. So this is just a little practice question. I actually used Davis's PowerPoint for this chapter because it was kind of straight and to the point, and there are only certain things that you really need to focus on here. So a mother is caring for her 9-month-old baby who has a respiratory syncytial virus, which is RSV, and is calling the pediatrician's office for advice. She reports that a baby appears very anxious and fussy when the baby lies down. She has noticed nasal flaring with the baby. Which of the following would be appropriate recommendation by the nurse? A. Try a cool mist humidifier. B. Allow more time for the baby to rest during activities. C. The baby is in respiratory distress and needs immediate medical attention. Or D. Administer over-the-counter cough cold medicine to help alleviate the symptoms. So the answer for this is C. The baby is in respiratory distress and needs immediate medical attention. So you really need to know what signs of respiratory distress are and when they need to be evaluated. So if the baby had just been crying, coughing, maybe having a little bit of wheezing, then not necessarily they would have to come in. But the fact that the baby had nasal flaring, was crying and restless when they were laying down. Those are and nasal flaring. Those are really signs of respiratory distress. So you need to teach them these signs and symptoms and make sure they're seeking medical care appropriately. So next we have roseola. Typically, you'll see it's a viral illness that most commonly affects young kids between 6 months and 2 years of age. And you'll see as far as symptoms, they'll have several days of a high fever, and then they'll have a very distinctive rash just as the fever breaks. It is typically seen due to human herpes virus 6. It's transmitted by saliva of persons who've had the disease or are carrying the virus. Apparently, 75% of adults actually carry the virus in their saliva without having any symptoms. Incubation period is a 9 to 10 day incubation period. The rash itself will be pink or red papular rash. And then, like I said, after the couple days of a fever, then it will return to normal. And the fever itself will typically be pretty high. It's going to be about 103 degrees Fahrenheit or higher. So the biggest thing you want to monitor for is febrile. Then rubella or German measles. This is caused by, of course, the rubella virus. You'll see, as far as symptoms are concerned, adolescents will have a mild fever, malaise, sore throat, and a headache before the rash occurs, but younger children won't really have many symptoms. You may just see the rash itself. It's airborne through respiratory droplets or direct contact with secretions. It can also be found in blood, urine, and stool. Incubation period is about 16 to 18 days, and they can be spread from a week before the rash until 14 days after the rash appears. And the rash itself will typically start on the face. It's a very fine red or pink rash, and then it will begin to start to spread downward on the body. And it will last about 3 days and actually will disappear in the same order it appeared. So if it starts on the face, it'll disappear on the face first. And we have, last but not least, for this MMR sequence is going to be your rubeola or measles, and it is caused by the measles virus. It's airborne through respiratory droplets or direct contact with secretions. So if you see airborne on these slides, obviously it's going to be airborne precautions if they're in the hospital. Have an 8 to 12 day incubation period. It can be spread 1 to 2 days before prodromal symptoms, and that is when prodromal means symptoms that occur between when they're infected until the rash appears. So prodromal is before the rash, but between the rash and when they get infected. So they'll get infected, they'll have some symptoms, and the rash will occur. So it can be spread 1 to 2 days before they start having symptoms, 3 to 5 days before the rash, and then 4 days after the rash appears. As far as the prodromal symptoms, the hallmark symptom, which is something you'd want to know of measles or rubeola, is going to be the Koplik or Koplik spots, however you like to pronounce them. And those are going to be inside the mouth, like on the roof of the mouth itself. And they're clustered white lesions inside the mouth. And so they're a hallmark sign for measles. They'll also have a fever, general malaise, a cough even. And I guess I should say, in addition to the spots, that may also have a bluish white center to them, so that's also a hallmark of the spots as well. The rash itself will be a brownish red macular rash. It actually starts in the hairline and then it spreads downward over the body. Another hallmark sign of measles are red, watery eyes. So if you see red, watery eyes, Koplik spots, you can guarantee that you probably have a measles case on your hands. Nursing interventions for this is just look for any type of complications. If they have any respiratory issues, just manage that and provide support there. And educating parents, when they go home, if a child's been diagnosed with measles, of course, fever management is going to be number one. They really need to be kept isolated for 5 days after the rash appears, because again, that's is so contagious. Um, if they have like crusty eyes, you can use a warm compress to remove crusty eyes because they're so watery, and then it dries. Because the Koplik spots can cause some pain, give them soft, bland foods, and make sure they're, most importantly, keeping well hydrated. So the last three that we talked about, the roseola, rubella, and rubeola, you will only see that if the kid hasn't really had an MMR, but you will. And here's just a little visual of the Koplik spots for you. Those don't really have a bluish white center, but those are they're those red little spots, and inside they should have a little bluish white center there for you. So chickenpox, very common childhood virus here. Um, Biggest thing with chickenpox is it is contagious 1 day before the rash appears, while the rash is spreading, and until all the vesicles have crusted over. So they are contagious from 1 day before the rash appears all the way until all the vesicles all over the body have been crusted over. So even if the child doesn't have a fever, is feeling better, if those vesicles on the body are still open, they cannot go to school. They need to be isolated. Chickenpox is transmitted by fluid from the vesicles on the body, which is why you got to make sure they're crusted over, secretions from the nose, mouth, and eyes, and it's actually also airborne from coughing and sneezing. So if you get a kid with chickenpox, you make sure they're on airborne precautions. The rash itself will start as macules in the center of the trunk of the body, and then they'll start to spread to the face and the proximal extremities. So it starts center of the body on the trunk. Then they progress from macules to papules to vesicles, and then the crust formation will follow. And then scabs will appear in approximately about 1 week of the scabbing over of or the crusting over the vesicles. They'll also probably have more than likely a fever, general malaise. Of course, this rash, these vesicles are very, very itchy, so you need to provide an antipyretic for them. It could be a Benadryl, could be something else, but make sure that you're providing that relief for them, especially at night. And they may also have a headache or dehydration, so make sure that they're taking in fluids, either IV if they're in the hospital or PO if they're a hospital, depending on what they can manage. As well, make sure that the parents know to do this at home. You also want to make sure you're educating the parents. Again, this is the other one. You have flu and chickenpox that you cannot give, especially aspirin for. Avoid aspirin. You don't want to have that Ray's syndrome. So only use acetaminophen to relieve fever. Keep the child isolated until all the vesicles are crusted over, as we mentioned before. Keep them well hydrated. Prevent itching. So to help with the itching, keep the child cool because heat just irritates and makes it more itchy. Apply gloves or mittens if necessary. You'll see like younger kids, if you see them in the hospital, we actually have diapers wrapped around their hands as little mittens so they can't itch themselves because it's so itchy. They can have an Aveeno or oatmeal bath, and baking soda baths can also help bring relief for itching. Calamine or Cetaphil lotion can also be applied to lesions, so it's not against the rules to apply anything to help with itching on lesions themselves, so you can educate them on that. Interestingly enough, though, it is possible to get chickenpox twice. The second time is usually a bit more mild with less fever and fewer vesicles, but the care is still going to be the same. And if you've had chickenpox as a young kid, as you get to be an adult, the virus itself is, hanging out latent in your body. And so later on, when you get older, conjunctivitis or pink eye, I'm sure we've all had this once in our lives. You can actually have viral or bacterial. Viral appears secondary to some other type of viral infection and will clear on its own in about 1 to 2 weeks. And then bacterial will start in one eye and then spread to the other and then clears on antibiotics. So if you see it occurring in one eye and it's not in both, more than likely it's bacterial. as opposed to viral, especially if they hadn't had a virus recently, so you guarantee that it's a bacterial um, conjunctivitis. And of course, you could have an allergic one as well, but your two main ones are going to be your viral and bacterial. And it's spread during from direct contact. You'll typically see pink or red color on the sclera of the eyes. The conjunctiva will be swollen. It'll have excessive tearing. A yellow-green or purulent discharge will come from the eyes. And then in the morning, their eyes are like crusted over, can barely open them. And sometimes that may not be that severe, but you'll see they're nice and crusty for you in the morning. As far as nursing interventions, you're just kind of keeping the child comfortable and administering eye drops. The biggest thing you want to do for parents is education. So obviously this is very contagious. Encourage them to tell the child to not touch their eyes. If they do touch their eyes, they really need to wash their hands really well. They need to sanitize any objects that have been touched by the eyes or the hands. And then as they wipe their eyes, they need to discard those tissues because it can live on there, and if somebody else touches it and puts it in their eye, then they're going to have a pink eye themselves. As far as administering eye drops, it's important that the parents know to not touch the dropper to the eye or any surface, because if they're touching the dropper to the eye on pink eye, it's just going to live on the surface of that dropper. So every time you're sticking it in there, it's not, I mean, it's going to be a continual issue. Or if it's an eye drop that they need to use later and it's resolved, then it's going to reintroduce the infection to the eye. So do not touch the dropper to the eye. You want to make sure that the child, when they're putting in, it tilts the head back and they pull down the lower eyelid. Then they want to drop the medication drops into the lower eyelid pouch right there. And the child should close their eye and gently press the tear duct in the corner of the eye with a little tissue, and then they need to wipe off any excess solution that comes off and throw it away and wash their hands. Then we have pertussis or whooping cough, which is very common. It's contagious from the onset of symptoms and for about 2 weeks after the symptoms begin. Infants who are not immunized may be contagious for at least 6 weeks. It's actually spread direct contact and droplet, and then indirect contact with freshly contaminated articles. There are different phases of this. You don't have to know the exact name of the phases, just know the first phase lasts from 1 to 2 weeks. They'll typically have cold symptoms, mild cough, and fever. And even something called coryza, which is the mucous membranes in the nose are inflamed. The next phase lasts 1 to 6 weeks or longer, and that's when the cough starts to end with a crowing, like a whooping sound, and they can cough so hard, the pertussis, I mean, they get in these coughing fits, so they may start to vomit, or they just can't catch their breath, so they'll become cyanotic. So you don't want to put them in that coughing fit. You want to try and prevent that from happening, kind of like the RSV bronchiolitis. Pertussis can be even worse. So they can cough so hard that it elicits their vomiting response, and they'll vomit everywhere. And I have it on my other computer. This is what whooping cough sounds like. Hopefully you can hear this. And that child there, like, she just can't even stop. She's crying because she can't catch her breath. And so she's just like choking. So it has like, and they cough, cough, cough. So it's pretty pronounced. You really want to make sure that parents are educated on getting their child that DTaP shot, because that has a pertussis immunization in it. They should be getting one at 2, 4, and 6 months, and then anywhere from 15 to 18 months, and then sometime between 4 and 6. But 2, 4, and 6 are the main times they need that DTaP shot, and that is huge in preventing this pertussis. And it's a really, really serious and big issue. Just to give you an idea, CDC the last statistics they had from 2000 to 2014, there were 277 deaths from whooping cough or pertussis in the United States, and 241 of the 277 were babies younger than 3 months. So you can see how serious it is, and that even when your baby has been immunized, people come over if they're sick, tell them to stay away because lots of people want to come see the baby and they don't think about having a cough or a sneeze. You don't want to expose the babies to any type of illness. And the last phase in pertussis is the recovery phase, and that's when the cough gradually becomes less severe. And depending on what the issue is, sometimes the cough can be last for weeks. So it may be less severe, but it still may be present. As far as nursing interventions, of course, if it's severe or they're diagnosed, you want to monitor their respiratory status and provide them with support as they need. Caregiver education, this is a really big one because they do have risk for vomiting and they're coughing so much. Make sure that they're giving their child small amounts of fluid, but very frequently to keep them hydrated. Because if they're vomiting, if you give them too much, it may exacerbate a coughing episode, and then they're going to have all that in their stomach and they're going to throw it up, and you're going to be back to square one. So just do small amounts of fluid. Teach them signs and symptoms of respiratory distress and dehydration, and then the sooner they seek medical care, the better. So the minute they feel like something's wrong, they should go ahead and seek that medical care, because the sooner we can get them treated, the better the outcome's going to be, especially if they're itty bitties. And you want to make sure that they're getting lots of rest, and you're teaching them to have quiet activities with their child and avoid any type of stimulus that may trigger a coughing episode. And a cool mist humidifier may help with that as well. In your PowerPoint, if you're looking at it, you actually have slides for a question about a strawberry-like tongue, and it talks about the enterovirus, and that's incorrect, so I deleted it. So if you're looking at this and you see that question, just mark it out with your pen because that answer for that question is incorrect. So just quickly, we're going to go over just a few bacterial diseases. Strep throat or scarlet fever can be spread for 10 days without treatment, and they're not if they do get treatment, they're not contagious after 24 hours while they're on antibiotics. And so the difference between scarlet fever and strep throat is that strep throat is strep throat, streptococcus infection, fever. Scarlet fever is when you have a rash with strep throat diagnosis. Now you may be thinking, well, if they have a rash with strep throat, earlier you said it could be mono. That's if they get a penicillin, amoxicillin, or ampicillin. If they have a streptococcus infection and then they take a ampicillin or amoxicillin, then develop a rash, that could be mono. However, if they're presenting with a strep throat and a rash at the same time with no medication, then that's scarlet fever. These kids will present with a sore throat, fever, headache, enlarged and tender anterior, cervical, and tonsillar lymph nodes, abdominal pain, and decreased appetite. However, not all these symptoms have to be present to have be diagnosed with strep throat. Of course, you're going to do a swab, but you'll see that there are lots of people who end up being carriers, and they may have a sore throat or not feel good without many symptoms, and then they get swabbed, and bam, they have strep throat. A lot of times too, if you have a kid that comes to the doctor's office and they don't complain of a sore throat, you'll see that kids under 3 years of age may have a fever, very irritable, and a runny nose, but they don't have a sore throat. But when you look back there, you may see something, or if the doctor is skeptical and maybe want to just swab them, they may very well have strep throat as well. So kids under 3 may not complain of a sore throat. As far as a scarlet fever, the rash that you'll see will be a fine red rash with the texture is going to be very much like sandpaper, and so it's really pronounced in the armpits and the groin area, and then you may also really see it in the creases of the elbows and behind the knees. After the rash fades, a lot of times you may see that the skin that's affected around the fingers and the toes may peel, and they may also have kind of pallor around their mouth, so they'll be discolored and lighter in color around their mouth, and a white tongue. And they may also be seen with a very swollen strawberry tongue. So if you hear anything about a swollen red strawberry tongue, think scarlet fever. Okay, that's important. Scarlet fever, red strawberry tongue. Scarlet fever is when strep throat's with a rash. Strep throat is just strep throat. A complication of strep throat can lead to rheumatic fever. So if it's left untreated or the kid's not responding to treatment, then it can lead to rheumatic fever. But you don't, just kind of be aware of that. You don't have to know it. As far as caregiver education, typically there might be penicillin ordered if the child is not allergic. And if kids are allergic to penicillins, you may typically see them be treated with like an azithromycin or clindamycin of some type. Also want to make sure that they're keeping their child hydrated because there is lots of tenderness in the throat. Soups that aren't too hot or broths, popsicles are good. And they kind of, some people say milkshakes. However, milk does cling to the back of the throat and can cause further issues. So I would not go with milkshakes when you have strep throat or scarlet fever. I'd keep it clear, something thin. Don't do anything milky because it can hang out back there and cause further issues. Also want to treat fever and pain with acetaminophen or ibuprofen. Definitely want to replace the child's toothbrush. You may want to get them a new one like during while being treated, and then after the treatment's complete, go ahead and get another one. And then throat lozenges also help. Also, sometimes like cool salt water or a little warm salt water gargles can help. Putting some salt in some water, have it gargle it and spit it out. Okay, now I have signs of respiratory distress, and you guys need to know this slide. No ifs, ands, or buts. You need to know this slide. Restlessness or anxiety is a sign, especially a kid who can't talk. If they're real restless for no reason, they could be having respiratory issues. A respiratory rate over 60 in infants and over 40 in toddlers. Look at these numbers. I'm just going to tell you to know 60 and 40 because you really need to know all respiratory rates. And I told you guys for the last test to focus specifically on that chart that I had posted. Don't look at anything else, but there were still people that were looking at the wrong things. So for testing purposes, I'm going with 60 and 40, okay? So anything over 60 in infants, which is birth to 1, is going to be respiratory distress. Anything over 40 in toddlers, which is going to be 1 to 3, is going to be respiratory distress. I'm not going to try and trick you. It would be an age in between, but no 60 and 40. You need to know more than that, but for this testing purpose, 60 and 40. Retractions, do they have suprasternal retractions, meaning it's above the sternum and the clavicle area? Are they pulling in? Intercostal retractions, which are going to be in the intercostal spaces, you can see them kind of sucking in on the sides. Substernal retraction, which is going to be right there underneath the sternum below where you would do CPR, is going to be retracting in. Or subcostal retractions, we're going to be on the bottom end, on the inside of the stomach area where the bottom half of the ribs are. They'll be sucking in there. So be looking for retractions. Listen for wheezing, distress that increases with lying down. That's not a good sign. Breathlessness, gasping, or continuous coughing. Excuse me. Nasal flaring, color changes, crowing sound when they're taking a breath. That could be pertussis. If they have a crowing sound, a hoarse cry or barking cough. A barking cough is going to be bronchiolitis or RSV. So crowing is pertussis with a whooping cough. Hoarse cry or barking is going to be bronchiolitis or RSV. Lastly, we have signs of dehydration. Again, you need to know this. Are they lethargic? If there's no tears when crying. For young infants, if they have less than 5 to 6, we're going to go with 6 wet diapers. If they have less than 6 wet diapers in 24 hours, they are dehydrated more than likely. Remember, 6 to 10 is normal. If they're less than 6, don't look at this 5. If they're less than 6, then that's an issue. If their eyes are sunken in, you remember for infants, if their fontanelle is sunken as well, and then if their skin is not elastic, they have poor skin turgor, then that's an issue. And that wraps it up for chapter 22.